In this lecture, we will cover the clinical specimens and infections as it relates to the clinical microbiology lab. Now, first we need to understand that each microbiology lab may operate just a slightly different. And so each laboratory will establish their own guidelines as far as the type of media that they will use and how they will handle the various specimens that are sent to the lab, but for the most part they're going to follow a general outline. Now, some of the different media that's differential, a lab may choose one type over another for whatever reason, so there's not really a right or wrong way to do that as far as deciding exactly which media to use, because there are a couple of different ones. But for the most part, all labs are going to use something like a sheep blood agar and a McConkey CNA, chocolate, those kinds of things that are more supportive or that are more widely used. But as far as doing some of the identification of some of the organisms based off of different media types, that will be just preference for that particular laboratory. But to set up a culture, once the culture is received into the laboratory, it goes through a process of being logged into the laboratory system, whatever that may be, whether it's a handwritten document or through some sort of electronic information system. But various things will be checked for, like making sure that the sample is properly labeled, has the patient's information, whatever identifiers that are used for that particular facility, as well as things like the collection date and time and what the source is. Now, this information is very viable to the actual laboratory as far as when they're setting up the culture. They need to know the source so that they know how to properly set it up to make sure that you are cultivating all of the possible pathogens that can be in that source. You always want to be sure that you're checking your labels and requisitions and things and making sure that you're matching them up so that you don't miss any test, or and also to look for any kind of errors or discrepancies that may be present with that sample. And of course, you want to investigate and resolve any of those before you move forward. Now, once you have the sample and that first step has been performed, then of course you're going to evaluate your sample for the quality of it and make sure it's suitable for the particular culture that has been ordered, making sure that the sample has not been contaminated in any way. For example, urine containers, a lot of times patients or staff don't properly seat that top on that urine container, so it's kind of sitting on it a little sideways, and the urine will leak out into the transport bag. And of course, at that point, that transport bag would be considered contaminated because it's not a sterile product there. And if the urine is leaked out into it, then it's possibly introduced bacteria that wasn't originally in that sample, and so it would be considered contaminated. Whether or not it was stored properly in shipping and things like that. So there's a lot of things that you'll have to kind of just look at that sample, and you got to be familiar with that sample in order to be sure that it is something that you can set up in culture. You may possibly, depending on the sample source, need to perform a direct microscopy of that sample. And so you could do this by something like a gram stain, a methyl blue stain, acid-fast, just whatever your particular facility uses as their way for doing those various stains for that particular culture. Some physicians may request a gram stain on something that you wouldn't normally do a gram stain on. So you want to be sure that you're looking for that and documenting those results, because as you recall, a gram stain is going to give you that first early indicator of what the potential organism is that you are dealing with in that sample. And then lastly, you will select and inoculate the appropriate media for that particular sample. And then you will incubate it at the proper temperature and atmosphere for whatever particular organism you're trying to cultivate. And so most of your cultures will be examined about 24 hours, 18 to 24 hours, depending on your site and what their criteria is. Depending on the sample, some samples might incubate for 2 days before you actually read them, but your site will have those procedures in place for those particular samples and cultures that you're going to be performing. Your anaerobic cultures, of course, would need to go into the special incubator or the bag or whatever is used for those anaerobic cultures. And then, of course, they will typically be looked at and reviewed for an extended period of time for those anaerobes, give them time to grow. The microbiology department itself will establish these guidelines, so be sure that you are reviewing those guidelines for that particular department and not just going off of what you may see or learn in a textbook or in a course. Throughout this presentation, I will give you the information that is listed in the textbook, which will include this table that you see on here where it just describes the various tests that will be performed based on the particular site that that culture was obtained from. And so we're going to look at whether or not it typically would have a gram stain and the primary plating media that you would use for that specimen. And so we're going to look at things like sheep blood agar, CNA, McConkey chocolate, the modified Theo-Martin, the HE agar, any sort of a gram-negative type of agar, or a broth, a thio, any sort of media that might be for an anaerobic type of bacteria, PEA, and the KV. The KV is going to be your the kanamycin and vancomycin laked blood agar. And so we'll learn a little bit more about the various organisms that would be cultivated using this particular media, but for now what we're going to look at is the particular specimen and what you would culture it on, and kind of start understanding why you are doing the cultures in this manner. So we're going to kind of start out learning based on a specimen and what typically grows in that specimen, and then we're going to kind of dive a little deeper into those particular organisms that would typically be found in those specimens. A UTI, or a urinary tract infection, is an infection that can affect pretty much anywhere throughout the whole urinary system. So basically what will happen is you can start with a pathogen that will enter in through the urethra, and then it will migrate up. So once you get in the urethra, you can actually have an infection of the urethra type of area, and then it can move up into the bladder, become a bladder infection. From there it can kind of work its way up towards the kidneys and infect the kidneys as well. So anything throughout that system can kind of progress up that urinary tract if the infection is not treated in a timely manner, or if it's treated with a particular antibiotic that will not kill that particular organism, then it can kind of continue to work its way up until it reaches the kidneys, and then can potentially cause further damage to the kidneys as well. You do have a couple of different type of infections as far as how they're acquired. You can have a community acquired infection. So this is just one that you're going to get just by various things, just based off of the anatomy, the immune system being weakened and things like that, dehydration, various things that can cause just an infection within the urine. And some of the more common bacteria that are seen are listed here. Now, I'm not going to go over each individual bacteria because we're going to learn about them. For now, we're just going to focus on which ones are most common, which ones will you see in these particular sites, and then we're going to kind of, our future lessons, we're going to kind of learn more about the different organisms and bacteria that we'll kind of talk about individually. There's also healthcare associated, so we kind of think of this when a patient might be having some sort of procedure or something of which would introduce that bacteria, or just bacteria that you wouldn't normally have with or wouldn't normally be introduced to just in a normal everyday setting, but they could be introduced through, let's say, catheterization or some sort of treatment or anything, you know, a pelvic floor exam, things like that, that could potentially introduce that bacteria into the urethra and then further travel up and cause infections. Urine specimens that are submitted are generally just going to be a clean catch midstream urine, but occasionally you may get specimens that are through just a straight in-out catheterization or some sort of indwelling, more permanent catheter, or a suprapubic aspiration, just where they go straight through the skin into the bladder to aspirate that urine sample directly from the bladder. Of course, if the sample cannot be processed right away, then you would need to refrigerate it or use some sort of preservative, and this is where those a lot of physicians' office will use those little yellow tubes in which they use to siphon up a little bit of the urine, and then it goes into that tube that has a preservative in it to keep any sort of bacteria in there from multiplying to give false results. You can do a screening with your chemical strip. Of course, if leukocytes or nitrite are present, then it can indicate that there's an infection going on. You could potentially screen with a gram stain, although most places aren't going to do this. It's just not cost effective and timely efficient to do a gram stain on every urine, since most places are going to do that screen with the urine dipstick anyway, and possibly a microscopic examination in the urinalysis department. So that would already lead to the idea that there is some bacteria present or white blood cells indicating an infection. And again, just a reminder that a colony count is performed on urine specimens. So if you look here at this culture plate here, to do that setup for urines. Now, most cultures are just going to do that 3-quadrant streak, but for urines, you're going to do that streak down the center, and then you're going to cross streak it. You're going to come back over that original line and cross streak it, and then you're going to do your colony count there. So depending on where your colonies grow, how many you have, then you're going to actually quantitate those based off of the particular size of the loop that you use. So with our clean catch midstream urines, we use our 1 microliter inoculating loop, and then when we do our colony count, we will multiply that count by 1,000. If it is one of the suprapubic or the catheterized urines, then you would do your counts. You would use the 10 microliter loop, so it's going to be a little bit bigger, and then you're going to multiply your count by 100. Now, the facility that you're at will have the criteria of what they're going to call as far as things like if there's multiple organisms, they'll let you know. If it's greater than a certain number of organisms, then we consider the sample contaminated. They will also set the criteria for things like if it's more than 10 colonies that are present, then you would work it up. If there's less than that, just say you only have 1 or 2 growing, then you might not work it up. But they will set that criteria, so be sure that you're reviewing that criteria for your particular lab. So here's the chart that just explains the particular specimen that you're going to have and what you're going to set it up on. Now again, most samples that are submitted are going to be a clean catch. So as you can see, you may or may not do a gram stain. It's highly unlikely that you will do a gram stain unless it was just specially requested from the physician. But you're going to set that sample up on a sheep blood auger and a McConkey for sure. Depending on your lab, they may add in some things like a bile esculin just to do that early screen to look for that enterococcus. Some labs might use some of the other gram-negative media to kind of help with identifying some things. So it just depends on your particular site, but most places are going to stick to just a sheep blood auger and a McConkey, maybe possibly bile esculin, depending on how many urines you get a day and whether or not it's more cost effective to do that bile esculin first and time efficient to get that early identification. Now some labs will actually use a split plate for their urine, so you've got the blood auger on one side and then you also have the McConkey on one side. This could be potentially if you have like laboratories that have satellite sites and things like that, where they'll kind of go ahead and streak that urine plate, set it up, and then send it to the larger hospital lab to actually do the workup. So sometimes you may see these plates come in from physician's office and things like that as well. But as you can see, pretty much the same media is used for all of the specimens except when you're dealing with a suprapubic aspiration, and so there's some additional media that might be added for that. We're going to talk about an organism. It's called a vancomycin resistant enterococcus, and of course this is what I was referring to as far as that bile esculin plate. There's a special plate that they will use to kind of help work that up, or it may be that test may actually be done through automation. So that can vary from lab to lab. Gastrointestinal tract specimens and infections. Now with your GI tract, these cultures, I will tell you up front, they look crazy because the GI tract, as we know, has a lot of normal microbiota in the large intestines that kind of stop any sort of bacteria from actually colonizing and causing any sort of infection. So there's a lot of normal flora. And this normal flora consists of gram-positive cocci and rods, various anaerobes, as well as various gram-negative rods. So not seeing bacteria in the culture is actually abnormal. So if you were to set up a culture on a stool specimen and there was a lack of organisms growing, or a very small quantity, or a lack of what you consider normal flora, then that's an issue, as well as seeing organisms that aren't considered normal flora. So that can be a problem as well as seeing things like yeast and other things like that. Now the gram stain of a normal stool, it can look very busy. Again, you've got those gram negatives and you've got those gram positive that are going to be present in that stool sample. Now the microorganisms that are associated with gastroenteritis can actually cause infection in several different ways, and one of those ways is actually by the production of various toxins. So you have things like enterotoxins, and these will lead to fluid loss and electrolyte loss, and there are some various organisms, different organisms that produce these enterotoxins, and we're going to talk about those as well. You have cytotoxins. So cytotoxins will actually cause the epithelial cell destruction within that GI tract, which can lead to an inflammatory disease and tissue destruction, and this is going to be evident by the presence of neutrophils and red blood cells in that stool sample. So this is one of the reasons why a gram stain is often done. And there are various organisms that do have those cytotoxins that do cause that damage. Neurotoxins, and what happens here is the acetylcholine is actually blocked, that acts on those nerve junctions that will actually result in a paralysis. There's also various organisms that can be pathogenic, and so these organisms will actually infect the patient by attaching or actually colonizing that GI tract. And there are some bacteria that do this, but usually we're more focused on the parasites and the viruses that actually go through this process. Stool specimens should be processed within 2 hours of collection, or they should be placed in some sort of transport media. So occasionally patients may be sent home depending on what particular organism is suspected to cause that infection. They'll be sent home with one of these containers here, and some other type of sterile collection container, like a larger one, for them to actually get the sample of their stool and add to these smaller containers here that will help with preserving that specimen. So depending on if they want to look for parasites or anything like that, or just bacteria, just depends on what they're looking for, will depend on which collection container is actually used. Direct examination, of course, with the gram stain, you're looking for those fecal leukocytes or those red blood cells to indicate that there's if there's particular infection or the organism is actually causing any sort of damage or anything. You could potentially do some sort of viral antigen testing on that stool culture, or any kind of kit type testing. Sometimes a stool may be submitted that's not in any sort of preservative, just to look for the hemoglobin that may be present, just checking for the presence of that blood in that specimen, of that occult blood. And of course, there you could do things like C. diff testing and things like that, looking for those antigens and things. Depending on the patient's history, a physician may suspect something, and so they may kind of tailor the test based off of that patient history as well. Depending on the lab, now they may require, they may just do certain cultures or certain media, like just if they're just doing a stool culture, might just be blood agar, McConkey, and HE, and then some other gram-negative type of agar to set that culture up on. The sites may choose to add things like the sorbitol McConkey to look for certain organisms, or even some of the other different rare media to kind of detect things like Vibrio, or just to kind of differentiate the Salmonella, Shigella, and things like that. But here you've got this list. Again, refer to your site. Don't go by this list, but this just kind of gives you a general idea of what you will use to culture these particular specimens. Of course, genital tract infections, now they can also affect the urethra, but as well as the vagina and the cervix. So we think of the urethra type of infections to be seen in male patients. Here are some of the various organisms, which include your bacteria as well as your viruses and fungal infections. The specimens, of course, you can get directly from the cervix, the urethral discharge, things like that. We should avoid cotton swabs. Cotton swabs can actually affect the organisms themselves that we typically find in these specimens. So it's usually going to be something like a Dacron swab, or some sort of special collection kit that is used for these specimens. Here we have some examples of what you would see as far as the infections with these organisms. So when you're doing your gram stain, this could be what you would see. This sample here is showing the gram-negative diplococci that is actually intracellular, so you can see it inside of those white blood cells. You can see those little gram-negative cocci that are inside of those cells. This other picture here just gives an example of a clue cell. So we talked about this in urinalysis, where the bacteria will actually coat that epithelial cell, so you can see some gram-positive organisms coating that cell. As you can see, there are a lot of organisms that you will need to be aware of as far as these specimens, because each of them kind of has their own unique requirements as far as how to cultivate them or how to find them. However, even though we can cultivate these, a lot of these organisms can be tested now through other automated type of methods, through molecular methods, fluorescent stainings and things like that. So trying to cultivate them really isn't as hard as it used to be, because we do have more advanced testing now. But there are several listed here. I'm not going to go through each of them, but you can just kind of review them and just be aware of what organisms you will typically see in these specimens. Here again we have an example of the specimen source and the various media that will be used on them. As you can see now, sheep blood agar is pretty much going to be set up on everything. Unless you're suspecting something like an anaerobe or something like that, then you would have to make sure that you include media that is going to enhance the growth of those as well. Skin and wound infections. Of course, our skin does have normal bacteria that does reside on the skin. So you need to be aware of those, and that normal flora that's on the skin could potentially be introduced to some of the deeper layers and then cause infections there. Some of the different infections will include things like bacteria, fungus. Occasionally you can have some deeper infections, so you can have some anaerobic type of bacteria that could be present as well. And then, of course, depending on the particular bacteria, it can cause things like the necrotizing fasciitis, where it actually destroys that deep tissue and then spreads out and can become systemic and can eventually, can make its way to the bloodstream, other organs, and then, cause patients to lose limbs and things like that as well. And it can potentially lead to death as well. Cultures for skin and wound specimens should include collections with needles, so just kind of aspirating out that infectious material. You want to avoid swabs with cultures. They're not really great for allowing your anaerobes to grow. And of course, when you're dealing with anything that's deep within the tissue in the body, you do kind of have to suspect the potential for an anaerobe. These cultures may require you, depending on your site, it may require you to do a gram stain of that particular specimen. Here you can see a gram stain of a wound in which there's a lot of gram-positive cocci present that ultimately led to the identification of Staph aureus. And in the background here, you can see a lot of debris. So the gram stains in micro can be a little confusing when you take it from direct specimen sources. Because you do have that little bit of kind of debris that does stain, so it does make it a little bit harder to recognize, but this is a pretty good stain here. And of course, you're going to set up your culture. It's going to include the sheep blood agar, and then you're going to try to include media that would differentiate between gram positives and gram negatives for your aerobes, and then of course you're going to include your anaerobic media as well. Respiratory tract infections. Now we do have a lot of normal flora that do reside within the respiratory tract, so you have to be familiar with this just to be sure that you're looking for the actual pathogen for that particular specimen and not let some of the normal flora confuse you. Throat cultures, of course, typically we're looking for the organism that's going to cause strep, and of course you're going to swab the areas of inflammation to just kind of get that tonsil area, because you don't want to bring in any of the normal flora that resides within the mouth. Swabs are going to be used to isolate that specimen on blood agar, and remember that with our blood agar, we're going to be looking for the result of that hemolysis in that agar. So this is where the hemolysis comes into play when we're doing throat cultures and looking for a particular hemolysis pattern to be present in our throat cultures. And so we're going to talk about that in more detail when we talk about the strep pyogenes. If you're suspecting, or the physician is suspecting that there's something else that's causing this patient's infection, then they may request the culture to include things like a chocolate agar looking for Haemophilus, or if they suspect that there's a yeast infection that's present, they may state that, as well as some of the other potential infections that are a little bit rarer but could still be present within that specimen. Upper respiratory tract infections, of course, is going to include like your sinuses, your nose, throat, nasopharyngeal area. Typically your sinuses aren't going to be cultured. Now if there's something that's going on and physicians suspect something like maybe there's a fungus ball or something growing in the sinuses, then you may get a actual a culture from the sinuses, but they're going to be more of a specialty, and so that's usually like an ENT physician is going to be the one to submit those and then request that you look for something in particular. The anterior nares is just where they kind of screen the opening of the nasal path just to see if the patient is a carrier of MRSA. And so this is your methicillin-resistant Staph aureus. And of course, they're going to screen that on a special agar to look for that. And a lot of times you will see this in patients pre-surgical. just to see if that patient is a carrier, so that they know that once they do that surgical procedure that they need to be aware that this is a potential for this patient. Your nasopharyngeal samples is going to go up through the nose, along the basement of the nose, and go all the way back here to the nasopharyngeal area to get that actual collection. So this is where they go for like your flu swabs and things like that. Viral specimens are going to get a nasopharyngeal. Your lower respiratory tract, so of course this is going to be once you get lower into past that throat area where you've got all that normal bacteria. These areas are usually sterile. You're going to, if a patient has symptoms like bronchitis or pneumonia or something like that, then a physician may do some sort of culture, or let's just say they're in there doing any sort of procedure, biopsies, or doing any kind of bronchial wash or anything like that, then you may get those cultures from that. Usually it's going to be looking for some sort of signs or bacteria that could be causing pneumonia. So you could have some sort of colonization that's happened within the patient's lower respiratory tract. Maybe the patient inhaled some sort of microorganism. Maybe it was introduced through some sort of a ventilator, or it could be potential that the patient maybe had an aspiration and introduced that bacteria over into the lower respiratory tract. There are healthcare associated pathogens as well as community acquired pathogens as far as it's related to pneumonia. Now, if a sputum culture is sent, then of course it's looking to diagnose some sort of lower respiratory tract infection. A gram stain is performed in order to enumerate the number of squamous epithelial cells, because if there are more than 25 of those epithelial cells present per low power field in that specimen, then it kind of indicates that that it's contaminated by saliva and not that it's not actually sputum. So the sputum is going to be kind of coughed up and induced, and coughed up, and that sputum itself is going to be put into a container. However, sometimes patients will cough and can't really get that productive sputum up, so they'll just spit, and they can kind of contaminate it with just more spit than they do the actual sputum sample. Now, with these samples, you're going to inoculate it on blood, chocolate, and McConkey. And of course, you're going to be looking for the presence of any sort of acid fast bacteria or mycobacteria that could be present. Here are some examples of some gram stains. Of course, this gram stain up here that's kind of yellow. You can see a lot of these epithelials that are kind of grouped together right here. Here's like a single epithelial. So there's a lot of epithelial cells in this sample, so it kind of indicates that it's possibly saliva and not sputum, which means we could be seeing some of that normal flora that's in the oral cavity and not something that's from the lungs. Here we have some gram stains that include, at the bottom here, we've got our gram stain of our sputum that shows some mixed flora. So you have some gram positive, gram negative, as well as some of these larger cells here, which are yeast. This other sputum sample is showing some gram-positive cocci that look like they're probably some sort of strep or strep pneumo, because you can see where it's kind of that lancet shaped for that organism. And then you can also see a lot of the white blood cells that are present. So all of those white blood cells kind of indicates that, yeah, there is an infection going on. And here we have our list of media based off of the specimen that is submitted. Spinal fluid. So with spinal fluid, we're looking for some sort of infection within that meningeal layer or that barrier that's covering the brain, as well as within that spinal fluid. A patient could potentially get an infection because they've had some other infection, like a sinus infection, ear infection, that kind of progresses through the nasopharyngeal and then eventually works its way in towards the bloodstream and then is passed on through other sites throughout the body. It could be introduced through trauma, surgery, or any sort of congenital defects that it actually allows that bacteria to enter into the spinal column. So the CSF fluid itself is basically an ultrafiltrate of the plasma. So when we are assessing spinal fluid, of course, it can go through hematology, chemistry, as well as micro. So when you get those tubes submitted, you need to make sure that the correct tube was drawn in the correct order and submitted to the correct department. For chemistry, when they're doing these tests on the samples looking for glucose and protein, depending on what those results are, will depend on as far as leading towards whether it's a bacterial infection versus a viral infection. Now, the glucose of the spinal fluid should be about 60 to 70% of that of the what's actually in the serum. So you're going to correlate this with the actual serum results that are taken somewhere around the same time to get that glucose level, and then you're going to kind of compare it. If it is a glucose level that is decreased, then that's going to indicate that it is bacterial. If your protein is increased, it is going to indicate that it is bacterial. So if the bacteria are actually living in that spinal fluid, they're using up that glucose, and so that's why you see that decrease. And then their byproducts and stuff is going to kind of increase that protein. And then, of course, if you're doing a cell count in hematology, if you see the presence of blood cells, that's going to indicate that that tap is traumatic or there's some other hemorrhagic type of issue going on there. If you're seeing a lot of white blood cells, then, of course, that's going to indicate that there's an infection. Of course, a fewer number could mean that there's a viral infection. Seeing a presence of neutrophils versus lymphocytes is also going to aid in determining if it's bacterial versus viral. Now, your spinal fluids, the organisms that can cause the infection, it can be various bacteria as well as fungus. A patient can have encephalitis. This is typically going to be due to viral infections. And there are a variety of viruses that can actually infect the brain. Here you do have some gram stains, again, of some intracellular organisms that are present in that spinal fluid. Now, just as a reminder, those plastic collection tubes do have numbers on them. You have to be very careful because a lot of times they're a little harder to see, so sometimes they're not always collected in the proper order, so the people that are collecting it, the physician and nurses or whoever's assisting, will handwrite on those labels and put them on the tubes and won't necessarily go by the actual number that is engraved on that tube. So you need to be very careful and make sure that you are testing from the proper tube. Usually tubes 3 or 4 are going to go to micro because hopefully any kind of contamination that was maybe present on the skin didn't make its way to those tubes, so that kind of come out and collected in those first tubes that are going to chemistry, so that hopefully no potential contaminations in those last tubes. And so you're going to process it immediately. It is not to be refrigerated. If you can't get to it within a few seconds, you do keep it at room temperature. Do not put it in the refrigerator or keep it at body temperature. But anytime a spinal fluid is sent to the lab, it is considered a stat because that's not a sample that's easy to collect. You do not want to put somebody through a spinal tap multiple times. It's not fun, it's not easy on the patient, and it runs a lot of risk. So a spinal tap it should only be done when you really suspect that that's where the issue lies. And then once you get that, it is a stat test. So you're pretty much going to stop what you're doing to process your spinal fluid. You will need to concentrate it, so you'll do this through some sort of mechanism like doing a cytospin or using some sort of membrane filter to make that sediment and then ultimately stain and plate that sediment. Hopefully all of your organisms have been reduced down into that sediment and you will be able to catch them. Now your workup is going to include a gram stain or some sort of stain depending on what you're looking for, and of course plating it on your media, your blood agar, McConkey, chocolate, or anything else that's going to be appropriate for that particular diagnosis, and potentially based off that gram stain. If you see something in there that is out of the ordinary, then you may add media based off of that gram stain. You could potentially do some sort of rapid detection, like doing an ND ink stain, looking for the capsule of those fungus, or looking for some sort of rapid test kit that's looking for something. You could also include PCR or nucleic acid amplification methods in order to detect whatever it is that you are looking for. Other body fluids, typically any kind of fluid in the body is going to be sterile. You're going to collect it with a needle type of aspiration. And of course, you're looking for any sort of effusion. And so this is when you're going to have some sort of accumulation of that fluid in that cavity. A transudate is going to have that low protein level and specific gravity. It is usually because there's some sort of hepatic or renal disease that has caused some sort of changes that's going to lead to the accumulation of that fluid within that cavity, or an exudate where you have a high protein level and a high specific gravity, and this is going to be a result of an infection, or could be a malignancy, trauma, some sort of toxic compound, or something else that has caused some sort of inflammatory process to take place within that cavity. These specimens will require some sort of centrifugation in order to create that sediment that you will gram stain and use to inoculate your media. You could potentially do some sort of testing on it, like glucose, protein, in chemistry, as well as hematology might do a cell count looking for the number of white blood cells, or doing a differential on those counts. Of course, if you have neutrophils, that's going to indicate that it's bacterial, where your lymphocytes are going to indicate viral. Pleural fluid, this is the fluid that is around the lungs, and it's usually going to be secondary to something like pneumonia. Here we have the infections listed, as well as the media that are typically used to inoculate it. Peritoneal fluid, this is the fluid that is surrounding the abdominal cavity. You can have your transudates as well as your exudates. The infection within the peritoneal fluid, or in the peritoneal cavity, is peritonitis. And here we have the organisms listed that are pathogens, as well as what you would inoculate your specimen on. Pericardial fluid, of course, this is the fluid that surrounds the heart. You can have infections from viruses as well as bacteria, and of course the media here is listed to inoculate it on. Synovial fluid, this is going to be the fluid that lines the joints. And then as far as the infections that can happen, you can have various infections from various organisms, just depending on how it's introduced, but you can also have infections from prosthetic joints, and this is because of those biofilms that are created by those organisms. And we also have here listed the media to inoculate these specimens on. Here you also have that list of comparison of the various fluids and the media that will be used to inoculate those specimens. Blood cultures and bacteremia. So bacteremia is going to happen when you have bacteria that enters the blood. You can have a transient type of infection where the bacteria is kind of spontaneously released into the bloodstream, an intermediate where there's just a periodic release, or continuous where there's a continuous release. Septicemia is a systemic disease in which the microorganism and the toxins are present in the blood, and then this can ultimately lead to septic shock and even death. There is an intravascular type of infection which begins in the blood. This can be a result of infective endocarditis or intravenous catheters. And then you have an extravascular, in which the bacteria enters the blood through some other source. So this will be like an infection that's somewhere else, and then it kind of progresses and makes its way to the bloodstream. Blood cultures, of course, require the proper cleaning of the venal puncture site. You don't just use normal alcohol. You want to avoid any of those skin contaminants. This is why you have to do the proper cleaning, where you make that circle starting in and working your way out with something like that iodine. Timing of the specimen collection, of course, just one specimen collection is not sufficient. So most sites have a policy in place where they will collect 2 to 3 sets of blood cultures over a 24-hour period. And of course, those sets will include an aerobic and an anaerobic. You could also include other bottles depending on what the site's policy is and whether or not you suspect that there's an infection with something like microbacterium or fungi. Most of your blood cultures are going to use that SPS, which will inactivate your neutrophils and antibiotics and then inhibit various components of that complement or coagulation cascade from taking place. And it can also inhibit the growth of some of your bacteria. So this is why if you suspect particular organisms, you might need to do a particular bottle or special things to kind of enhance the growth of those organisms. So your bacteremia can be a result of gram-positive cocci, gram-negative bacilli, anaerobes, and fungi. Some of the other specimens that our textbook lists will include eye infection, which can be caused by an aerobic, anaerobic bacteria, or fungi, viruses, or even parasites. Your ear infections typically aren't cultured, but occasionally you may have some patients in which the infection's not resolving with traditional treatment. So maybe they want to kind of figure out if it's something that's resistant or something like that. So they may actually do that culture by pulling that fluid from that middle ear and culturing that actual fluid. And here we have a list of some of those various things that could be cultured. Now, all the things that I've discussed, again, this is not an exclusive list. It's just covering some of the more common cultures that you will see. You can get other things like bone marrow. If they suspect that there's a deep infection within the bone marrow, you could get bone marrow for culture. You could get bone for culture, bone fragments. You could get actual tissue from different sites. So your site or your facility that you're at should have a list that will include various potential sites or sources and what you will need to do for those. But if you're ever in doubt, it's always better to add more than not have enough. So if you're ever by yourself and you're working a shift and you feel like you're not exactly sure and there's nobody to ask, then throw in everything. Just throw it all in just to be on the safe side. Yes, it's wasting money, but it's always better to be safe than sorry, because you didn't include something and so you've caused problems with working up that particular sample. So if ever in doubt, always ask.